5, 6. You can go to the next question.
Yeah, till the time.
Okay, so
One has-
only one has got it right. That is iliolumbar vein and sacral vessels. Okay, next. Next question. So we should be giving the. Okay, so Amit has scored.
Okay.
Next.
This is the next question.
We have only one answer there. So comparing transperitoneal and retroperitoneal approaches. 2. We have 10 seconds left. Okay.
So three have
We have got
correct.
it right, which is superior visualization is there seen in transperitoneal, but the rate of retrograde ejaculation is more. Okay, next. Okay,
still-
so Dr. Amit is on the leaderboard, and yeah.
the next question is this.
We have no answer.
Okay, three got it
So
right.
3 got it right that there is delayed fusion does not always correlate with poor clinical outcome. So now Vikrant is on the top. Next. Question. So if you answer it early, we can. Two of you are yet to answer. Okay, 5 of you have got it right. So most of it is during exposure. Next. Okay, now Amit is on the top, but Shwetab is rising up.
Oh, great. So you all have answered right. Like 5 of you have answered right. So
Next, only 5 questions. Next. Okay, at the end of the quiz, Amit is the leader. So we'll continue with the rest of the questions. Although Vikrant had the highest answer streak of 4. Okay.
अरे छोटा है
Rakshay to start with the
Good morning, everyone. Respected dignitaries, esteemed faculty members, dear colleagues and participants. On behalf of the Department of Neurosurgery, AIIMS New Delhi, it gives me immense pleasure to welcome you all to the Cadaveric Workshop on minimally invasive spine surgery, themed anterior and lateral approaches to the lumbar spine. This workshop is designed to provide a focused cadaveric learning experience, emphasizing surgical anatomy, approach-related nuances, and practical execution of minimally invasive lumbar spine techniques. I would like to first welcome the respectable dignitaries on the dais. Our chief guest, Professor P.S. Chandra sir, head of the Department of Neurosurgery, AIIMS New Delhi, whose visionary leadership and academic excellence continue to inspire generations of neurosurgeons. So I'd like to welcome you on the dais, sir. Next, I would like to welcome on stage our guest of honor, Professor Shivanand Gamanagatti, Acting Chief, Trauma Center, a stalwart in trauma imaging and multidisciplinary trauma care. Welcome, sir. Now, I'd like to welcome the workshop director and the Professor Deepak Aggarwal, sir, Professor of Neurosurgery at AIIMS New Delhi, whose tireless efforts in advancing neurosurgical education are widely acknowledged. Professor of Orthopedics, Professor Vijay Sharma sir, is yet to join us, and he'll be probably joining us soon. Next, I'd like to welcome on stage Organizing Secretary Dr. Surya sir, Assistant Professor in Department of Neurosurgery, who is the workhorse of this workshop. May I now request our respected dignitaries to kindly come forward to the dais and for the lamp-lighting ceremony to commence this academic event on an auspicious note with invoking Saraswati Vandana, symbolizing the illumination of knowledge and ignition of fire of learning. May I request Professor Rajendra sir also to join the auspicious. Professor Anand sir, please may you also join, sir. Now I would like to request Professor Deepak Aggarwal sir, the workshop director, to kindly address the gathering and share a few words.
Thank you, Rakshay, and all the dignitaries on the stage. Professor P.S. Chandra, the chairman of this workshop and head of Department of Neurosurgery, and Gamma Knife, Professor Shivanand, my friend, and he's the chief of the trauma center now acting, and he's also looking after the radiology department here. And in absentia, Dr. Vijay, who's heading the cadaveric lab. I welcome you all to this workshop. This is a unique workshop meant to highlight the different approaches to the spine which we do not usually use, and I think these have become more and more important to learn as the world moves towards minimally invasive surgery. And Surya has worked a lot to ensure that this workshop goes smoothly and we all have a great learning experience. We have kept it deliberately a very tight boat, in the sense that we'll have only 2 people per cadaver, hopefully, and you will get to learn what you will see by the experts. And obviously I welcome the faculty here who's going to teach you in this workshop. So thank you so much.
Thank you very much, sir. Professor Vijay Sharma sir probably is unable to join us, but conveys his best wishes for the workshop. Guest of honor, Professor Shivanand Gamnagatti, acting chief, we are thankful for your presence, sir, and his best wishes are also conveyed for this workshop. Now I would like to request our chief guest, Professor P.S. Chandra sir, Head of Department of Neurosurgery, to share his thoughts of wisdom with us, sir.
So good morning to all of you on this cold winter morning. So at the outset, I would like to congratulate Professor Deepak Aggarwal and his team, along with the Trauma Center, for having very substantially and very persistently going on work, organizing this series of very important workshops. And obviously, you know, the best learning that you can get closest to an operative experience is cadaveric experience. And that's the strength of these workshops. So you have the masters coming here demonstrating you, and you will have the closest ever hands-on experience on performing the surgical techniques on cadaver, and that's the highlight of these courses. So I congratulate all of the team for having organized it, and I also thank all the delegates for participating in it. So you have to understand that this is a very niche area. So the ratio of the cadaver to delegates is very high. So you get the maximum opportunity to do this. And just to give a word, you know, if you do a similar courses anywhere in a Western country like US or UK, you would be paying something like $3,000 or $4,000 per person. So you should keep this in mind whenever you are attending these courses, because the knowledge behind it, whatever has been given, is very substantial, and you should try to make the best utilization for this. So thank you once again.
Thank you very much, sir. We'd like to welcome Professor Vijay Sharma, sir, in charge of ACSST Cadaver Lab Laboratory. Now I'd like to request Professor Vijay Sharma, sir, to kindly address the gathering with his valuable words.
A very good morning to one and all. On behalf of ACSST, I welcome all of you, all the esteemed faculty members, Professor Chandra sir, Dr. Shiva, Dr. Deepak, and all the delegates. I welcome you all. As Dr. Sharat Chandra said, it's one thing is, if you look at the program, yesterday we finished one oral surgery course. Then last week we had lung transplant training course by Dr. Rajshekar, Dr. Devaguru, and day after tomorrow we are starting a plastic surgery course. So this week was like, this month is very busy for the cadaveric lab. So I appreciate the efforts by all the staff members. They are working there. They work from morning to evening just to make these courses as smooth as possible. So my best wishes to all of you, and I'm very sure you are going to learn a lot from this course. All the very best. Thank you.
Thank you very much, sir. May I now request Professor Surya sir to take.
Yes.
So good morning, everyone, all the dignitaries. So thank you for having me here. So these kind of workshops are very important to strengthen your skills, as sir said. So make full use of it, and so that you can apply it in your day-to-day practice. And we have one of the best cadaveric facility under the guidance of Dr. Vijay Sharma. So regularly we are conducting all these workshops, and it is a busy workshop schedule this year. So make a full use of it and apply these skills in a day-to-day practice. Thank you so much.
Thank you, sir. Now we would like to felicitate our expert faculty. We are fortunate enough to have Dr. Anand Naik sir, who is the current director of spine surgery in New Delhi Spine and PSRI Hospital. He has extensive experience of around 21 plus years and has pioneered numerous advanced techniques like lumbar hybrid disc replacement, XLIF first in Asia, robotic navigated spine surgery. and he has been associated with various institutions in Australia, USA, Singapore, Malaya, South Korea, and Italy. And he's peer reviewer of various international journals and has numerous spine patents to his credit. Thank you, sir, for taking out time from your busy schedule. And sir is extremely passionate about teaching ALF and lumbar discipline. Thank you, sir. I request our chief guest, Professor Chandra, sir, to felicitate Dr. Anand Naik, sir. Dr. Umesh will join us tomorrow, so we are fortunate to have him. And sir, I'm fortunate to have Professor Rajendra sir, a surgeon par excellence, and I would say, I don't know, it's my fortune or misfortune, but this might be sir's last association as invite faculty in our workshops, as sir will be proceeding to greener pastures very soon. Thank you, sir. I would like to thank Professor P.S. Chandra sir, head of the department, for being the guiding light and giving us a free hand in conducting these workshops. Dr. Shivanand sir, Dr. Kamran sir, for providing the logistics and for his go-getting attitude, and Dr. Vijay sir, in spite of having a busy schedule in the cadaver lab, he always comes forward to provide us with the cadavers, and the cadavers are really good actually. And Professor Deepak Aggarwal sir, as you are all aware, I think he conducts the maximum number of workshops. I think that should be one of the records in India. Yeah. And I thank the industry sponsors, Globus. So they have taken efforts to provide us with specific instrumentation for this workshop. And I thank all the delegates for taking out time. Thank you all. With that, we come with the end of this inauguration ceremony. I request all of you to join for a group photograph.
हेलो हेलो
बोल बोल
हेलो हेलो साउंड चेक 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 हेलो साउंड चेक
मेरी आ रही है
हैं
मेरी आ रही
हाँ हाँ आ रही है
है हेलो हेलो
आ रही है
सुन
हाँ
कोई नहीं, एक ही आदमी चाहिए.
It's for me, 7:55 sharp, 7:55 morning, as usual, start sharp, ठीक शाम को 7 बजे ground. Yes. See, I was very upset when आठ, सवा आठ, साढ़े आठ, you know. तो तुम हो गए, मनमोहन हो गया और रवि भी हो गया, तो सुनते नहीं. सीनियर लेवल पे बहुत है, बाकी तो डीएनबी से सबसे ज़्यादा एक्चुअली वो वाला लॉट है, सर वो कितना है? मेरा पास 3 है, एक डीएनबी,
इसको हटा, इससे इतने केस असिस्ट करे और ये लीडर है.
So please settle down. We'll start with the presentation. Thank you. We shall be starting with the presentation. Please settle down.
Whenever you see similar looking faces, you think more. How come you flow all the way from Uzbekistan to Maldives? So you were earlier trained in your Uzbekistan or somewhere?
Yeah. I trained in University of Name.
We went to Maldives I think 3 or 4 times for that.
Last
ADP
time,
was-
yeah, it is very inspiring. You in the Dr. Kamra, yeah, so
There are 3 Indira Gandhi, Tito, and then how many people are in Tito? Doctors.
consultant 90 and now we are
I think there were one of the neurosurgeons from India also.
in Indira Gandhi Hospital.
So in Maldives there is a hospital called Indira Gandhi Hospital, that is very big building, made with India sport, one of the fantastic hospitals. They pay very well.
Okay, I shall be discussing the anatomy relevant to ALIF procedure and few indications. And I request Dr. Anand Naik sir to please interrupt during the presentation and tell his tips, important tips which are required during the surgery. So for the ALIF procedure, you should know what are the structures at risk. Okay, so then we have the IVC with the bifurcation to common iliac veins on either side. Then there's the aorta with bifurcation of common iliac arteries. Then there is a sympathetic plexus in the form of superior hypogastric plexus with sympathetic trunks on either side. And then there is a median sacral vessels, that is artery and vein, in the midline. So important to note here is aorta is in the midline and IVC, you're all aware that IVC is to the right. Aorta bifurcation is usually higher, that is at the level of L4 vertebral body, although there are variations where it can be higher or lower. The important vessel while doing ALF, most important vessel is the left common iliac vein. Okay. Usually the origin is anterior to L5 vertebral body. So for a L5S1 ALF, already the bifurcation has occurred. The iliocaval junction is above L5S1 disc. But there are variations which I'll be describing later, where it can be either be high or low. Usually the left common iliac vein courses lateral to the L5S1 disc. But sometimes you must be aware that it can lie directly over the L5S1 disc. You must also be aware that median sacral vessels are always present in front of the L5S1 disc, although they may not be in the midline. So median sacral artery is not the correlate for midline of L5S1 disc. This is the important point. And important structure in the prevertebral space at L5S1 level is the superior hypogastric plexus. I'll be telling the importance of it. And this sympathetic plexus on the anterolateral aspect of vertebral body on either side. And you must also be aware of lumbar segmental arteries and something called as iliolumbar vein. So the approach is, we have progressed from a transperitoneal to a retroperitoneal approach. And this is the anterior abdominal wall anatomy. So there's something called as arcuate line, which is denoted here, which divides the rectus muscle. So below the arcuate line, that is below, arcuate line is somewhere between the umbilicus and the pubic symphysis, and below the arcuate line, the anterior rectus sheath is formed by the fascia of all the three muscles. Okay, whereas above the arcuate line, it is in three layers where it is formed by the corresponding external oblique, internal oblique, and transversus abdominis. Whereas below arcuate line, they combine together to form the anterior rectus sheath. This is an important point which is utilized in the exposure. And these are the various incisions that are used for the approaches. If it is a single level exposure, we usually use a transverse incision. But if it's a two level exposure, we use a oblique incision. So after incising and elevating the rectus muscle, we identify the posterior rectus sheath and go as lateral as possible and incise it. Once this is incised, all these muscles are reflected to the left, and with the help of finger dissection, we create the retroperitoneal space. You can see the structures, important structures here, that is the sigmoid colon, and we follow this plane. Okay, and then here there is psoas muscle along with the ureter. So ultimate aim is to reach in the midline here. So any points till now? Any comments? Do you want me to go back?
No, it's okay. This is one of the approach which Dr. Surya is telling you to go lateral to the rectus abdominis muscle. And there are benefits to this approach, but there is also a drawback to this approach. The drawback is the rectus muscle, it gets innervated from above and below, and it gets its blood supply from the lateral towards the medial side. So when you are doing that, if you damage the muscle fibers, you may encounter a little bit of bleeding over there. And the best way to stop bleeding is put some pressure, wait, and then you can go ahead.
Okay. So, okay. So this is the, after doing this retroperitoneal dissection, there's the visualization of the great vessels. And there's an important structure which is visualized, that is the iliolumbar vein. So I would like to know, sir, comments of sir, whether do you routinely ligate it or preserve it, and in 1 level and 2 level surgery, or L4-5 surgery, L4-5 versus L5S1?
So it's very unpredictable. This vein is very unpredictable. You may see it, you may not see it. But if you see it, dissect it, ligate it, and then you go ahead with the surgery. And if you don't see it, don't look for it.
Okay. And do you dissect the great vessels throughout its length to prevent thrombosis due to retraction?
No, we don't dissect along the vessels. just go to the prevertebral fascia, and then you slowly and gently pull the vessels to one side. You don't have to dissect unless you get some stuck or very thick retroperitoneal tissue, then you have to dissect.
Yes, thanks. So the aim is to reach the midline, and once we so the important structure, as I've explained earlier, that left common iliac vein is the most important structure which needs to be mobilized, and this is how we reach the midline. So this is the visualization on exposure. This is the left common iliac vein and artery. This is sacral promontory. You can see the superior hypogastric plexus. And after elevating it from the promontory, this is another additional sympathetic fiber with median sacral vessels. Okay. This is the cadaveric photograph showing the same. You can see this is the L5 vertebral body and this is the L5S1 disc. This is the, you can see the aortic bifurcation is way higher. Whereas in this case, the iliocaval junction is roughly around L4-5 level. You can see the left common iliac vein courses along the lateral aspect of L5S1 disc in this case, but there are instances where it can lie exactly in the midline. As you can see here, the superior hypogastric plexus in the prevertebral fascia, which is bifurcating into two divisions, and there's a sympathetic chain on either side. And this is similarly a lateral view after resecting the psoas muscle. You can see some segmental arteries. Any points here?
No. Okay.
So, most important is to know the venous anatomy variations, and this is a classical article about 50 years back published by Harman, where he has illustrated over 440 cases of venous anatomy variations. So in about 70% of patients, this is the normal anatomy seen. This is the vena cava. There is the right common iliac vein, the left common iliac vein. So usually it is at the level of L4-5 disc, and the left common iliac vein courses along the lateral aspect of L5S1 disc. This is the normal way, normal anatomy seen. Although the iliocaval junction can either be low is at the level of L5S1 disc, or high at the level of L4-5 disc or in front of L4 body. The incidence is noted here. Okay, so in that case, so the importance is to identify the iliocaval junction, also the angle. So that if the angle is less, the common iliac vein will be more towards the center. Whereas if the angle is more, it will lie away from the midline, and there is a window to perform ALIF safely. In some cases, you can see that there is a good window. 50%. Yeah. So the bifurcation is more towards the left side, and this is most commonly seen in males. And this is a variant where there is a large left common iliac vein where the diameter is much more. It is seen in 25% of all cases, and most commonly in males. So males usually do not have a favorable venous anatomy. And this is the accessory vein, a large median sacral vein, which needs to be tackled during the surgery. And this is a lateral lumbar tributary, which is a variant seen in about 1% of cases. Any pointers here?
Yeah, so when you go in there, you can see any of these anatomy. Trust me, I have seen all of them. And even if you look at this one, the enlarged central sacral vein, sometimes you may misinterpret this as an common iliac vein. It can be this big. It can be the size of your thumb also. Okay, so if that happens, you don't have to panic. You just have to, dissect this vessel so that you can go below the vessel, because you have to roll these vessels to one side. And if it bleeds, you should have a control. So you maybe you can pass one of the, the arterial loops, the blue color ones. You can keep it there. and if it bleeds, just you can control the bleeding.
So iliolumbar vein, where do we encounter? And
So most of the times you see iliolumbar vein here at the upper 1/3 of the L5 vertebral body or near L4-5. One time I have seen iliolumbar vein entering into the L4-5 disc. So in that situation, what I did was I preserved the lateral wall of the annulus, ligated the iliolumbar vein, and preserved the lateral part of the annulus. So you can see all variations. So every time you open up abdomen, be prepared for any of these.
yes. So
Any of these veins, iliolumbar or the median sector, if required, we can take them down.
Yes, sir. Even if the bleeding is out of control, and even if you have to take the common iliac vein, you can ligate it, because it will develop some kind of a collateral and it will flow. But the only thing is that the patient will be having little bit of swelling in his legs.
so I'm not. So this is something a paper described by Capletus et al., where they have seen the MRI study of the iliocaval junction and left common iliac vein positions. So there are two classifications. One is for the iliocaval junction. So iliocaval junction at L4-5 is taken as 0%, and at L5S1 is one reference level, and the distance between this is divided into 33% each. And they have denoted the nomenclature of iliocaval junction as very high if the junction is 1/3 above the L4-5 level, high if it is within 33% of L4-5 level, low if it is over the L5 vertebral body, and very low if it is close to the L5S1 disc. Then coming to common iliac vein, they have divided, this is the midline which is passing through mid of L5S1 disc, and this is a line which is passing through the lateral aspect of the vertebral body. And then this they have divided into 33% each, and the location of common iliac vein is denoted as lateral, intermediate or medial accordingly. And what they have found in the cases is that most of the time the location of iliocaval junction is high, that is in 48% of cases, and it is lateral. So it is high, the junction is high, and also the location of the left common iliac vein is lateral. Although there are various combinations seen, and especially in male gender, it has been found that left common iliac vein is more medial. It is more medial. Okay. So in order to create that window between both the iliac veins, you need to retract a lot. So that there comes the possibility of common iliac vein injury. So any pointers here?
No, perfect.
So they have done.
In case suppose the bifurcation is right in front of the L5S1 or low lying or very low lying, so do you change your approach?
No, sir.
can still go
It's
ahead.
very easy because veins have elastin in it. So the speed of retraction is a key. When you think that it is stuck, just stay there for a couple of seconds and then you can move it across. Normally, the prevertebral fascia is very smooth. You can slide, you can glide, everything.
So is MR angiography a routine investigation?
It's not a routine investigations to be done.
But do you see the location of the veins in the normal MRI, in the axial images?
So very tiny veins are very difficult to identify on MRI, but you can almost see the major vessels there.
Yeah.
For example, here, these are the veins.
Yes. So this is an example of a high lateral. So this is a high iliocaval junction with a lateral course of the common iliac vein. It's quite lateral, whereas this is a lower variant of iliocaval junction. But even here, the course of the left common iliac vein is lateral, quite lateral. You can see there's a lot of window where you can perform the ALIF. Whereas in this case, you're seeing that the left common iliac vein is coming closer to the midline. So in this case, you'll have to retract more than normal. And here it is even crossing midline. So this is a dangerous variant anatomy, which one should be aware of while performing ALIF. Any point?
Can you go back one slide?
Yes.
So here, can you see this vessel? This one?
Yes.
Yeah, this is dangerous. So if you are planning L34 or L45, you need to identify and ligate that. Here there is variation. So it's branching off from the common iliac vein.
So these sequences, seems they take only extra 4 minutes of time, and it's a time of flight imaging. And
Yeah.
yes. So about the median sacral vessels, it is seen in 100% of cases in front of L5S1 disc. Okay, but important to note here that it is a poor anatomical landmark for midline. Okay, and these are various studies where they identified the distances between the common iliac veins, and yeah. So iliolumbar vein, sir has already told about the importance of it. So one must be aware of the location of the ilioceval junction and also the angles and the corridor between the vessels when performing ALF. So in cases where there is very medially placed left common iliac vein, do you go medial to right common iliac? Or,
So there is no fixed rule to this. For L5S1, always approach from the bifurcation. Take out the sacral, median sacral vein and artery, no matter how many of them are there, and always approach from the bifurcation. But in an anatomical variation where there is a tributary and the left common iliac vein is almost vertical, then you may have to, dissect that vein and then create a corridor. Whatever is comfortable and whatever angle you can enter the disc space, you can. There is no fixed rule to this.
So coming to the superior hypogastric plexus, which is an important structure to be preserved, we are all aware that sympathetic has a thoracolumbar outflow, and the L345 sympathetic outflow via inferior mesenteric ganglion continues as the superior hypogastric plexus, which is in relation to the left lateral margin of the aorta. And it courses along the left common iliac artery and vein in the prevertebral tissue at L5 level, and through the pelvic brim goes to the bladder and supplies the seminal vesicles and vas. But there is a considerable variation that it is plexiform in the form of around 60 to 80%. It is in the form of plexus. In a small percentage of cases, it can either be in the form of a single trunk or parallel strands. The important function of superior hypogastric plexus is it is responsible for bladder neck closure during ejaculation, which is so if it is damaged, it can lead to retrograde ejaculation. Okay. And it also another important function is it affects the motility of vas. It helps in the movement of the spermatozoa. So usually what we see it's a rare phenomena, retrograde ejaculation, but retrograde ejaculation is more common than sterility. The function of superior hypogastric plexus leading to motility of vas is more resistant to retraction than retrograde ejaculation. So any pointers?
So this is one of the complication, retrograde ejaculation, which has been overhyped. Actually, the incident in our series of around 1800 patients was 0.8%. And how did we do that? We did the urine analysis before surgery. We took the consents, we performed the surgery, and at a regular interval, 3 months, 6 months, 12 months, we took the urine samples and did the semen analysis. And it was found to be 0.8%, whereas in a normal population, general population, it was seen to be more than 0.8%. So it's a overhyped complication, and don't get feared because of this. You can get away from this very easily. For last 9 years, I am performing these surgeries in India. I still have to see someone coming back with a retrograde ejaculation. So there are two layers of the superior hypogastric plexus. One, it reflects along with the peritoneum. And the second one is present in front of the bifurcation and the junction where the iliac vein is common iliac veins comes and forms the inferior vena cava. So in the cadaver today, maybe we can identify that layer. And if you see that layer, don't get panicked, don't use your cautery, use either isocool bipolar or just use a blunt dissection with your peanuts and move it across. You will never get any retrograde ejaculation.
So as Anand sir has said, these are the tips: blunt dissection, and the annulus is incised in vertical direction because the course is from top to bottom. Avoid monopolar cautery, as sir has said, and usually they normalize over the course of time. Another symptom complication which after injury to sympathetic plexus is a cold limb. So any pointers?
So here, this is one of the funniest complication, the sympathetic plexus injury, where the patient will tell that one leg is feeling warm, the other leg is feeling cold. So if you're moving vessels from the left side towards the right, then the approach level or the side will feel warm. Opposite side will feel warm and the approach level will feel cold. So this is, most of the people, they recover within one season cycle. We still don't know the reason why. And if it doesn't recover, then it will stay there permanently. There are plenty of tests like ninhydrin test and the sweat test for the palm. Some people, the sole of the foot, some people, they put the pulse oximeter. They are very poor indicators. It's only after surgery the people will tell. And they discover if they go into a swimming pool or any cold area, they will feel that one leg is warm, the other leg is cold.
So coming to the indications of ALIF, I think these are the common indications in spondylolisthesis. Usually in low-grade ischemic and degenerative spondylolisthesis, ALIF is well established. And in degenerative disc disease, which can either present as mechanical low back pain or due to height loss leading to foraminal stenosis, but there should be no gross hypermobility. And in cases of degenerative lumbar scoliosis, or if you're performing a revision fusion surgery for pseudoarthrosis in case of maybe a previous TLIF. So contraindications being a previous retroperitoneal exposure due to surgeries or presence of retroperitoneal fibrosis, and in high-grade listhesis or severe osteoporosis. So any pointers?
So I would add a previous retroperitoneal approach. Once you are used to this approach, you can do this. You can approach retroperitoneal area for at least 4 times. One from the right side, one from the left side. For the second time, you may have to stent the ureter because the ureter will be stuck with the peritoneum. So you can very safely approach that for at least 4 times. And idiopathic retroperitoneal fibrosis, this is very important. You should not perform an ALIF. You don't know where is what, and you may cut a lot of things.
So how do you identify preoperatively?
So on an MRI scan, you see how is the prevertebral fascia, if you see the plane or not. And if it is fibrosis, there will be you will see white bright signal between the vessels and the vertebral body. So that is an indicator that it's a retroperitoneal fibrosis.
Okay. So what about in X-ray presence of osteophytes and
no, it doesn't.
calcification of great vessels?
No, if there is an osteophyte, then it's a bit difficult to move the vessel or retract the vessel.
Yes.
So I have to be very careful. It's not a contraindication.
Okay. So in high-grade listhesis, why do you think?
I will show you some cases.
Yes.
You can perform the high-grade listhesis,
Okay.
but once you expertise the normal simple surgeries, then you can
go
jump
ahead.
over to the high-grade listhesis.
So any other indications apart from this do you perform for?
No, perfect.
So we are all aware of the advantages of ALIF. So it is a direct access and ability to put a large interbody implant, better fusion, re-establishing lordosis, and reducing listhesis with distraction, achieving coronal and sagittal balance. Here we spare the paraspinal muscles and dural and nerve root retraction. So this is the weight load is mostly towards along the anterior middle column, and this is the principle based on which ALIF. various complications. ठीक. Okay. Thank you. Laptop.
So a disclaimer is that all approaches are good. So you can achieve results with the posterior, minimal invasive, even open surgeries, they are good. Open TLIF, MIS TLIF, they are all good. So this is one of the approach. And I will start with a few cases which were presented in the MERC, the Musculoskeletal Education Research Council, and educative arm of the Globus Medical. दूसरे में लगा दो। आ गया। So this is 38-year-old male, a 3-month progressive increase of back pain, which was 5/10, and it is mainly present in the buttocks and posterior thigh only. And over 3 months, it increased to 7 in the right leg and 2 in the 7 in the left and right is 2. Neurology, left L5 is weak, and it happened after 6 months of he underwent a microdiscectomy. I don't have those images. And then the walking time, the sitting time, everything decreased. Now the neurology is left L5 and S1. Motor was grade 3. The sensory were intact. EMG, NCV, H reflex and F waves both were absent in left L5. And these are the X-rays after the previous microdiscectomy or lamellotomy inflection extension views. Standing X-rays, and this is post surgery MRI. You can see the scar over there. You can see the previous surgical scar over there, and this is post surgery, and this is the situation here. Now again, the left L5, there is foraminal narrowing, and this is very symptomatic, and the patient is having grade 3 power. So how will you go ahead with this sort of a patient or in this kind of a situation? Can we have some answers from the participants?
So I think one of the main things that is there is left side is a severe foraminal stenosis, and we need to decompress that.
Yeah.
So one option would be to go again from a posterior approach, do a standard TLIF, remove the entire facet and decompress the nerve root.
Yeah, absolutely. So there are multiple ways to deal with this problem. The posterior approaches, they are good. Will you be very careful with the posterior approach, because left-sided he has underwent through the laminotomy over here. There is a defect there in the bone, and then there is a stenosis. Yes, so there will be chances of scarring, and you have to dissect around the nerve. There will be nerve handling, and the chances of damaging the nerve is more in this particular situation. So that's why an anterior approach in this particular patient will help you. These are more detailed MRI scans. So plenty of this thing available. So this is an anterior approach, L5S1, and the device which you see here is not a fusion. It's an artificial disc replacement. It's a single block bush device known as lumbar prosthesis elastic spine pad. So it's a viscoelastic device. What you don't see in between the metallic end plate is the polycarbonate urethane core. So he underwent an artificial disc replacement at this level. Approach is same. You can do a fusion. With fusion, you are restricting, you are blocking that particular segment for movement. So this is another one, a 57-year-old female. She's with a 6-month pain in the lower back with progressive increase over last 7 weeks. Back pain was 9/10, mainly in the buttocks, posterior thigh, calf. Left leg pain was 8, right was 4. There is left EHL drop, grade 3 in L5 and S1. right side was grade 4, and bilateral absent ankle jerk. Known diabetes for last 14 years, which is very well controlled. All conservative managements failed, epidural failed. These are the x-rays. So you can see the ischemic defect and the listhesis there, probably grade 2 or grade 2. And these are the standing x-rays of the patient. You can see she's morbid obese. And these are the MRI scans. There is no rocket science in that. You can see the exiting nerve on both the foramen. It's not looking good there. These are the CT scans of L5S1, and you can see the double facet sign here on the CT scan. So all the techniques are available. So what will you do here in this particular situation? Anyone?
There is grade 2 lytic listhesis with bilateral stenosis.
Yep.
So I've been doing the posterior surgery, so that's what I can plan for a minimally invasive interbody fusion.
Yeah, so posterior is always there. For all these cases, whatever I'm showing, posterior is always an option. But do you think that anterior can be done for this patient? Like ALIF, artificial disc replacement, obviously not artificial disc replacement, but do you think that XLIF or anterior to psoas or OLIF, anterior to psoas or ALIF can be performed in this patient?
Yes, OLIF might be a bit difficult, ALIF can be done, provided bone density scores are okay.
The bone density, they are not okay, they are osteoporotic. So what we did was anterior lumbar interbody fusion. So we did the anterior approach in this patient. Here, the aim is not to reduce the listhesis to grade 0. You just have to distract. You just have to create the neural foramen opening. And these are again different kind of cages. These are all titanium trabecular 3D printed cages. And you secure them with the screws. Will you stop here, standalone ALIF in this patient, or you want to supplement with the posterior? That only, with few cases you can tell. I have stopped doing any posterior approach in this patients. I don't fix them from the back because the cage are too tall. These are around 15 millimeter in height. I have different lordosis, 5, 10, 15, 20, 25, up to 30 degrees. I have all these cages available with me. I use BMP for fusion, all my patients. So I'm very confident about the fusion, and hence I have stopped doing any posterior supplementation. But in early cases, if you are not using BMP, if you don't have a very good quality of a grafting solution, then probably you do the posterior MIS percutaneous pedicle screws in this situation. So this is another one, a 36-year-old female, 3 years back pain progressively increasing, 2 weeks after a very long drive. Back pain was 9/10. The leg pain is 4 or 5 in a worst case scenario. The EMG showed right L4, and right L4 was grade 4 in power, and the left L5 was grade 5. Walking time was 5 minutes and sitting time was 5 minutes only. And these are the x-rays. Here again you will see the listhesis there, and these are the MRI scans. This is the MRI scan. So very clearly you can see the dome of the sacrum is all rounded off, and even the L4-5 is not looking good. So these are the CT scans of the patient. So again, would you consider an anterior approach in this patient? Posterior, yes, it can be done. Would you consider an anterior approach in this patient? If yes, then what will you do? Fusion of L5S1? I will go back. Do you think that L4-5 is okay, or you need to do something for that?
Yes, sir. We need to do something for that also.
What will you do?
Sir, it is.
Huh? Axial for L4-5 is here.
That's it, yeah.
This is L5S1. This is L4-5.
Sir, pardon once again that last question you asked.
Huh?
Sir, question.
L4-5,
Would you like to do something for L4-5 in this patient, or only L5S1? Okay, so I go back couple of more slides. She's having right L4, and right L4 is great for neurology.
Yes, sir. That's
Now, would you do something for L4-5? Yeah, posterior decompression. So that means you're going to fix L5S1 anteriorly and do the posterior decompression for L4-5.
Is the hybrid an option?
Huh?
This arthroplasty.
Yeah. So what we did was we did a discogram, and we saw that the dye is leaking from the back on the right side. So we did the fusion in this patient. Artificial disc replacement was an option. The patient is a very short statured, 148 centimeters in height, and the smallest available artificial disc was not suitable for her. So we had to do the fusion. We had to change our decision to fusion intraoperatively. So there will be a situation when you're not able to perform an artificial disc replacement, because here in this situation the footprint was very small. The bony end plates were very small, not fit for ADR. So we did the fusion for this young girl. So last one more, 40-year-old male, 3-year back pain. He underwent a microdiscectomy in January of 2022. Severe increase after playing badminton. Back pain was 9, left leg was as 8, right was 8. Neurology grade 3 power in both L4 and L5, and there was no comfortable position for the patient for more than 30 seconds. These are the x-rays of the patient. All of them are standing x-rays. The attempted extension and flexion views, you can see that it's almost straight. These are the MRI scans. So again, what will you do here? Previous microdiscectomy, L5S1, now neurology, L4 and L5, grade 3 power. You can see L5S1 is all damaged. There is a recurrence of the herniation. But also L4-5, you will see a black disc over there. And this is symptomatic. So what we did an hybrid fixation over there. Now this is an artificial disc replacement device at L4-5. It's again the viscoelastic one. And we did a fusion at L5S1. Why we did a fusion at L5S1? Why not an artificial disc replacement there? Yeah, because of the recurrence of the disc, there was a lot of scarring and the nerve root was very irritated. So you need to provide a quiet environment for the nerve to recover properly. If you place an artificial disc replacement in this situation, the patient will never ever stay happy, because the disc will be moving and the nerve will be irritated, and there will be no quiet space for the nerve to recover.
So
yeah.
what are your, so
Yeah,
we'll
yeah.
be discussing
Please ask,
the
please ask.
indications for disc replacement.
So I will come to
Yes.
the indications of disc replacements and everything. So these were 4 cases. All of them seem very simple. Okay, anterior approach, but every time the technique was changed, either intraoperatively, either the preoperative planning we could not execute and we had to end up with an ALIF there. So a lot of things can happen during anterior approach. In one of the live conference, I had to abandon L5S1 ALIF because the sacral slope was too inclined and we didn't have any instruments, and we were damaging a lot of bone in the sacrum. So there will be a situation when you may not be able to perform an ALIF at L5S1, especially the pubic symphysis. You cannot go beyond that, and the angulation is too steep. So be ready to abandon that procedure. Don't harm. Go ahead and do the posterior surgery. So with all this, I have seen all kind of complications and all kind of change of plans and everything. So the benefits of anterior approach for patient, it's a single operation and a very minimal blood loss. The complication rates are lower as compared to the other surgical techniques, especially the nerve injury or the nerve pain. Most of the people with the posterior technique, the nerve retraction, they develop a scar and there will be some kind of a nagging or a constant nerve pain, but you don't see anything over here. The functional recovery is very good, higher fusion rates because the footprint for the fusion is very high, and very minimal adjacent segment degeneration. In ALF, our 35 years of experience with my professor, Mobs and Matthew Scott Young, it was less than 4%. And for ADR, it was less than 0.1% at 35 years. And people, they go home faster. Now I am performing daycare lumbar disc replacement for a single level. For surgeon, you can treat discogenic axial back pain. We always target for the neurocompressive lesion. We see there is a compression on the nerve and we target that. But that happens only in 15% of the patient. But 85% times we never identify what is the reason for pain. The person, you get the supine MRI, everything looks good, but you get a dynamic MRI or a sitting or a standing MRI, flexion, extension, you will see the nerve is getting irritated. So you can treat axial back pain. It allows the best sagittal and coronal reconstruction. The OR time is less, and it's very easy and more enjoyable surgeries. So complications like Dr. Surya has told you, vessel injuries and thrombotic events, I always give thrombotic prophylaxis. And even after surgery, I give TED stockings to the patient, and Clexane can be continued up to 6 weeks. Ureteric injury, I had one ureter injury. It was in a revision approach, 5th time. So it can happen. If it happens, you need to identify, you need to send the ureter and you need to repair that. Retrograde ejaculation is very less, as I told earlier, it was less than 0.8%. Left hip discomfort is one of the most common complication after this approach, because when you are moving the peritoneum and mobilizing the colon, there is a nerve which supplies to the anterior part of the or the front part of the thigh, and one branch goes to the genital part. So this is one of the most common complications. It's temporary, it will go away within first 6 weeks. Peritoneal tear is another complication. If it happens, you repair this, and if you are not able to repair, you tear the peritoneum and leave it open. Uretary injury, usually it happens in revision. So, so I will change my presentation to the next one. So ALIF, anterior approach, lumbar ADR, why and how do we do that? So like I told you before, that degenerative disc is one of the most common disabling back pain, and we have only 15% times we identify the neurocompressive lesion, but 85% time we don't identify what is the reason for pain. We just tell patients to do some exercises, take some medications, change your lifestyle, and you will be okay. But you will see this 85% subset, it's affecting their quality of life. It is preventing them from going back to work. It is preventing them from any active lifestyle. So this is a degeneration cascade. We all know it starts with the circumferential tears, which goes to the radial tears, and there is disc space narrowing. It's not able to support the load. And also at the same time, the facets are also reacting. So it starts with the synovial reaction, ultimately to the capsular laxicity and the subluxation. So it's a symbiotic relation between the disc degeneration and the facet. And we all know that 67% of the lumbar lordosis is contributed by L4-5 and L5-S1 only. We all know that lumbar lordosis, it changes with posture. In standing, it's different. In sitting position, it's different. And it changes with age. There is 40-degree change in the young people and 25 to 30-degree change in old people. So life is a kyphosing event. We all will lose lordosis and we all will become more kyphotic as we age. We all know that there is various disc pressure when you are doing most of the activities. The most strenuous of these activities, sitting and lifting weights. That is not good. And standing, bending forward and lifting weights. So all these images, they are all from the orthopedic textbooks and some of the journals. They have been very well published around 45, 50, 55 years back already. And we know the function of the disc. It has got an elastic recoil. It distributes the load, and 80% of the load it transmits from the front, 20% from the back. You get a degeneration. It changes to 60 and 40 ratio. So how do we perform these approach? Anterior retroperitoneal approach, they are different. They are not a typical vascular surgeon approach. They are not a typical abdominal surgeon approach. It's slightly different. It assists on the spine, and also it protects and monitors the vessel throughout your surgery. it is not very difficult or time consuming. It may take only 3 to 5 minutes to reach to the anterior aspect of the spine. You don't need any x-rays, you don't need any navigation. Your fingers are your navigation, and everything is done blindly with your fingers. You just have to go to the retroperitoneal fascia, reflect it from the psoas fossa, and then when you reflect and mobilize the colon, you will identify the ureter, a cord-like thing. You come to the midline, feel the psoas, you can feel the vertebral bone, and then you can feel the pulsations. Once you are there, you just have to go a little bit more towards the right side. So this is one of the surgical video which has been published in the Journal of Neurosurgery by mentor, Mr. Mobbs. So this was a Phalanstein incision. You give an incision, you see the anterior rectus sheath there, the glistening white structure. We split the rectus sheath in midline and like this, or you may slide a finger and then you can use your cautery. This is the only time when you are using cautery and knife. Apart from this, you don't need any cautery or any knife or anything. You insert your fingers like that, use your peanuts or sponge on a stick, go all the way up to the right iliac fossa. You see the psoas there, and then you reflect everything towards midline. And once you are done, you can assemble your retractor system there. You can place various retractor. Here I'm using Liga clip to ligate the L5S1 anterior sacral vein. And yeah, so I will pause here. Can you see this vein, the blue color thing? This is the place where the left common iliac vein and the right common iliac vein, it comes and forms together. Most of the times we don't see the right common iliac vein. You don't have to dissect all the way. And then you can move it, you can slide it, push it with your peanuts and place your retractor blades there. Place your retractor blades there. This is the anterior annulus of L5S1. And then the second time you pick up knife is to do the annulotomy. Sorry. So today we have almost similar kind of a retractor system over here. And once you can play with them. Once you reach there, you do the anterior annulotomy. Be careful with your knife blade. Don't damage veins at this place. Take it out, insert your corbs. There are various instruments available. You can perform the anterior annulotomy, complete total discectomy with various pituitaries, caries and rhongia. This is a distractor. I place it there and distract, and then use your rhongers and everything to empty the disc space. Once you reach there, if there is any fragment which has gone behind, you can see the tear, you can pull the fragment out. It's just like an ACDF for the neck, basically. So all steps are almost similar. Once you are done, you measure the width, depth, height, and the lordosis what you want to give at this level. You can take the cage, fill it up with a bone graft and place it there. If you are performing an artificial disc replacement, you have to be very careful. The annular balance should be equal on both the sides. On the right, the lateral annular balance should be equal. And your device should rest on the cortical ring, not on the cancellous part. The margin of error with artificial disc replacement is almost zero. If you're off center, you're gone. The device will fail, it will subside, and it's very difficult to revise also. So these are the first generation of devices. It started with Fernstein ball. Surprisingly, in 42 patients, everything was in midline, perfect position. These were normal, ordinary stainless steel ball bearings, but almost all of them were revised. I got a privilege to revise one of the patient. I still have those Fernstein ball with me in Australia. So there are only 2 FDA approved devices which are currently available. The first generation, one is ProDisc, the second one is Activel. Activel is almost out of practice now. A lot of people, they are preferring ProDisc. Now in India, we have Bagheera, which is by Spine. It is CE certified, not US FDA. They have applied. Most of the devices, you will see the Charité, they were first generation, second generation, and the third. The nucleus, you cannot see the plastic in between, but there were some patients in which the plastic, it migrated backwards. They started putting a metallic ring to know where exactly that plastic is. most of the times you might have, if you do a literature search, you will see all bad things about artificial disc replacement. That the devices, they stop moving, they fail. So most of those devices have already been withdrawn, and there are only 3 or 4 which has tested time, and they are there for last 35-40 years now. ProDisc is one of them. These are the second generation devices, the M6 viscoelastic. It has got a polycarbonate urethane and the silk fibers. This has been withdrawn. 100% failure rate with this device within 3 years. The reason, they engineered it like a normal disc, and there was a friction between the silk fiber and the metal, and they ruptured. So they ruptured like a natural disc. And we had to remove the nucleus in some of the patient from inside the spinal canal. And this is the ESP device. This is the most widely implanted across the world nowadays. And this is all metallic. They are all single piece device. So it can withstand loads of 6,000 newtons at 45 degrees. And it moves at around 5 degrees in every direction. It has got a torsion and a vertical dampening effect also. So I have implanted around close to 6,000 of ESP devices till date in last 21 years. One of the designer for this device. So now we have the third generation ceramic devices, in which we have removed the metallic part, and now we have the ceramic. The core is same, we have ceramic. The trials will start from January 26 in India from next year onwards. So we got approval for 40 patients, and the trial will start from January. If any of you are interested, you can come over to my theater and you can see these approaches, because it's always better to feel the live tissue rather than a cadaver. You can feel how much force and what should be the speed of retracting vessels. So now there is an argument that fusion or artificial disc, which one is good? So in fusion, even if it is an anterior fusion, you will always lose motion, but the spine is designed to move. So that's why the fusion versus artificial ADR disc replacement, the argument, it continues just like the posterior and anterior stuff. So in fusion, there is loss of motion. There is failure to restore the disc height or lordosis, pseudoarthrosis. Again, we are trying to achieve a fusion, but we get pseudoarthrosis. But whereas in ADR, we are trying to achieve motion preservation, but we get fusion there. So it depends on the surgical techniques, how you are performing. The adjacent segment degeneration is very significant. It's very high in the posterior approaches. It's very significantly low in the anterior. Even in the fusion group, it's less than 4% at almost 40-year mark. If you are taking a bone graft, there will be donor side pain, but we don't get that in artificial disc replacement. Sagittal imbalance can be corrected by any of the techniques. So the rationale for disc replacement is remove the pain generator and dynamically stabilize the spine. And you maintain and restore the motion, the movement of that level. It decreases the adjacent segment degeneration. And now we are coming up with a paper where with an artificial disc replacement, it has shown that it reverses the facet hypertrophy back to normal, and also the adjacent segment degeneration, if there are any, and it doesn't warrant any surgical intervention. It goes back, it retains its nucleus, and it retains its consistency, and it regains. So this is the only way where the adjacent segment degeneration, if they go back to normal. The facet joints, they go back to normal within 3 to 5 years time, but that doesn't happen with any kind of fusion. So the indications, I have added few more. So internal disc disruption or purely axial back pain, degenerative disc, disc height loss, annulus, we all know that, purely axial back pain. ALIF or anterior approach, only up to grade 1 or grade 2 canal stenosis. If the stenosis is from the center, you cannot perform an anterior approach and you cannot get a relief. For those people, the posterior approach is much better, and you can do the MIS or open TLIF. If there is facet joint hypertrophy, say grade 3 or grade 4, it's not a very good thing to perform anterior approach only. But if you are adding a posterior approach, then I would suggest to go only for the posterior approach rather than to perform two different approaches. For artificial disc replacement, any facet joint hypertrophy which is grade 3 for ESP or viscoelastic devices is acceptable. For a mechanical device or a 2-part or a 3-part device, up to grade 2 facet hypertrophy is recommended. And fail conservative management, you all know that. So the contraindications for these surgeries: smoking, not good. If there is any overt psychological problem, the person is not normal, you're trying to explain him about this approach, he doesn't understand that, and he has any unrealistic expectations about the surgery, don't do these approaches. Approach related obesity, I place a question mark. Now we have good retractors here, you can do it in anyone. If there are any multiple previous abdominal surgeries, you have to be a bit careful about the approach. Don't worry about the peritoneal tear, that will happen, you can repair. And atherosclerosis, you need to be very careful. If you are moving your veins or artery to one side and if there is a calcium there, it can break. It can break, it can migrate, and it's not a good thing. So you have to be very careful in vessel handling during that time. And scoliosis, nowadays I am performing ADR in scoliosis, the viscoelastic, and with complete correction and preserving the movements. Past defect spondylolisthesis, not for ADR, yes for this thing, ALIF. Central stenosis grade 3 or grade 4, not advisable anterior approach. Osteoporosis, you need to think twice, you may have to supplement from the back with the percutaneous pedicle screws or with the kyphoplasty there. And if there are any abnormal vessels like infrarenal aneurysm, you can very clearly see them on MRI. You can ask your radiologist to simply extend the window and include the blood vessels there in the MRI images. So you can see if there are any abnormal aneurysms or anything. If you encounter an aneurysm intraoperatively, stop there, then and there. Get your vascular surgeon, talk to the patient, get the consent for the aneurysm repair, and then you can go ahead and perform this surgery. Don't try to touch aneurysm if you see encounter there.
So what about transitional vertebra? How do you approach them?
So in transitional vertebra, it's either S1 behaving like L5 or L5 behaving like S1. So you don't see lot of movements in transitional vertebra. There is only proximal and distal distraction. So you need to stabilize. So I will not recommend an artificial disc replacement in transitional vertebra. But fusion is always a good option. But also, if you look at the transitional vertebra, you need to see the transverse process. There are different grades in which they form a joint over there. Most of the people, they have problem at the transverse process and the where it is forming a joint or a cartilage or a fibrous band. You need to resect that. So I would recommend, if you want to do an anterior, if it is grade 1 or grade 2 classification, then you can get away with an ALIF. But if it is, very massive joint, very big joint, then ALIF will not be helpful for you. So patient selection criteria, I do all of them. MRI are usually, neurography very rarely. If the clinical examination is not matching, then I get an MR neurography. I have stopped doing CT discogram nowadays because neurography, if there is a black disc, I can get the neurography done. It will tell me whether the disc is healthy or not, whether there are white spots or not, hot spots or not. EMG in every patient, other tests like DEXA. If there is a sacroiliac joint suspicion, I do get a sacroiliac joint blocks done. So in the lumbar ADR, the target is to retain the maximum movement at L4-5 and retain the L5-S1 is only acts as a stabilizer. It doesn't move much. And these are the results at 15 years after surgery. This is the normal spine at L4-5, the mean center of rotation. And this is the mean center of rotation for L5-S1. And this is after 15 years, and we have almost retained the same mean center of rotation with an ADR. And hence these devices, they never failed. So almost zero pain, VAS 0, back and leg. They took time to recover as early as 3 months to 6 months, but they are all doing extreme sports, bungee jumping, whatever you can think of. One of them is a fighter pilot, so they are doing all of them. So everything is not rosy here. We have complications, and implant related is osteolysis. If you get an infection, you can get that. I have 3 patients with osteolysis now. With the viscoelastic device, this is one of the most what I would say, it's one of the most drastic complication. The viscoelastic device has to be in perfect contact with the bone. If there is any gap, there will be a dead space, and that part bone will form a lytic lesion because there is no weight transmission. So the function decides the form of the bone. So if there is no weight transmission, there will be lysis all around it, and eventually these will kind of either stop moving or they will subside. So for that we have to do a vertebroplasty at that particular level. Subsidence, we have seen, if it is a multi-level, always at L4-5, never at L5-S1 or never at L3-4. It was always at L5 as L4-5, and always the superior end plate which was broken, be it a fusion, be it an ADR multi-level. Not related with implants are retroperitoneal hematoma. So you have to be very careful when you are moving the rectus vessel to one side. You will see the superior epigastric vessel, and that is most commonly damaged when you're retracting. So when you finish your surgery, just see that if it is bleeding, ligate it. DVT, second most common complication, but ever since we started doing chemical prophylaxis and also the mechanical prophylaxis, it's very rare to have them. Wound dehiscence and then divarication of recti. This is one of the most common thing which you can see, and especially in the obese people. So if you see that the anterior abdominal wall is weak, just put a mesh and repair it, so that even there will be no incisional hernia. It's gone, that complication once and all. Left common iliac vein injury is one of the most common injuries. I have done it many times, and God was kind enough that I was able to repair that even before massive blood loss. So this is very common, and most of us, we panic if there is any vessel injury there, especially these big vessels. So your assistant and you all work as a team. If it happens, you put a mop there, put some pressure, look around, see what all things are available on your table, get your vascular support, see the liga clips, sutures, the vessel loops and everything, and be prepared and stay calm. Don't get agitated, because this is the time when the stress level goes up and you create more mistakes. Stay calm. You're not going to lose your patient. Stay calm. Gently remove the mop, see from where it's coming. You can either apply clips, or you can take the control of the vein above and below, and then you can use 80 or 70, 80, 90, 10, depending on what sutures you want to use. So if it happens, don't get panicked. It will be sorted out. We had a right ureter injury in one of the patients, so please say, but ureter injury in revision approaches, not left or right. It can happen. Even if you're approaching from the left side, you can damage the right ureter with the retractor blades if you're using too much of pressure. So today we will learn a little bit more in the cadaver, although the feel will not be like a normal people. So let's see how far we can. The vessels in the cadaver will be very stiff. It's very difficult to move them around. So, but we will get the feel how it works. And yeah, this is the complication osteolysis which I was talking about. So it happened there. So we had to do a vertebroplasty. All of them were stable. Never had any other complication. So these are various 3 to 4 levels we can perform artificial disc replacements. You can approach from L2, 3 all the way up to L5, S1. L1, 2 is not possible from anterior. Tomorrow, Dr. Umesh will come. He will talk about the olive approaches, which are really good for the upper level. And the ceramic disc, which I am showing to you, so we have developed the lateral insertion that is customized ADR. So every person, they need to get a CT scan done, and we do the printing and processing of that device. Everything is done with the help of University of Connecticut. So these are hybrids, various examples. I used to do a navigation for them, but it's overkill. It's simply waste of time. You don't need a lot of X-rays. Just a AP view to identify the midline. One shot is good enough, and lateral view to see where exactly your cage is. But very few X-rays, maybe 2, maybe 3 at the most. If it is 4 level, maybe 6 or 7. So no need for any navigation, no need for any neural monitoring, no need for any lot of X-rays. So the radiation exposure and everything is less. For usually the blood loss is somewhere between 10 to 50 ml depending on number of limbs. So yes, there are spurious arguments. I want to bring this up deliberately. It's a very experimental or a novel procedure. You will hear this if you're in private practice. You are all here in the medical college, so you will not hear this. But if you're in a private practice, you will hear this kind of argument. It's not novel. It's not experimental. It's there in the world for last 45 plus years now. It's axial back pain is a benign disease. It doesn't need any disc replacement, but you are changing the quality of life for a person. Rather than being unpredictable with unpredictable future in axial back pain, you're giving him pain-free life. The long-term data is needed. The long-term data is already available. There is a white paper by ISS. Previously, it was Spine Orthoplasty Society. Now it's ISS, International Society for Advancement of Spine Surgery. They have come up with a white paper in 2022, and they have done the meta-analysis with level 1 and level 2 paper, where artificial disc replacement has proven to be better than any approach, better than any fusion. And they are all class 1 and class 2 papers with more than 10 years data. Only indicated in discogenic back pain? No, it can be done in the radiculopathy. You can take out the disc fragment. You're doing cervical spine, anterior approach, same. So all those you can, it's simply yes, it is risky. You can damage peritoneum, you can damage bowel, you can damage ureter, you can damage IVC, aorta, the sympathetic plexus, everything which comes in your way. But you can repair that. But if you are doing it carefully, you will not damage them. It's very, very rare complication to have that. But the chances of irritating or making a scar around the nerve is more common in any posterior technique. So these are various papers, and we did the meta-analysis. I don't want to go into all these details. If you want to read, you can take the slides. How we assess the journals and what all tools we used, and retrospective, prospective, RCTs, everything. So sorry, it's going. So ADR versus fusion. This is all anterior approaches. So there is no statistical difference in the OR time. It's almost same because the surgical technique, the dissection, everything is same. It's only the implantation. And if we see the surgery related outcomes, they are in favor in terms of blood loss. They are in favor of artificial disc replacement. The surgery related outcome in terms of length of stay favors artificial disc replacement. The rate of complications is almost there, same, but slightly more in favorable of ADR. And then the rate of reoperations is very less in artificial disc replacements compared to the ALF. ODI, they are in favor of ADR. The back pain, axial back pain, they are again in favor of artificial disc replacement. The leg pain, again in favor of artificial disc replacement. The difference in leg pain, we don't have papers which are showing this data for more than 2 years, but again they are in favor of leg pain. So the conclusion is of all this whatever I have spoken so far, and the meta-analysis and all these studies, there is no significant difference in OR time. The estimated blood loss is almost same. It's just like the MI, it's slightly more than MIS TLIF, but it's very comparable, very less. The complication rates are very less in anterior approach. ADR is associated with very significant relief in back pain, leg pain, and it provides the similar outcome in long term when compared to any kind of fusion. So this was a position statement which I was talking about. It's published there. It's a white paper by ISS. So the take-home message is artificial disc replacement is not for every patient and is not for every surgeon. If it is done in a proper way, says better than a fusion. But if it is done in a very bad way, it's worse than any kind of fusion. You cannot, the margin of error is almost zero with artificial disc replacement. You have to find the center of rotation. If you don't, it will fail. So I would say that a badly done ADR is worse surgery compared to any kind of spine surgery. So thank you, everyone.
Can I ask one question? Like,
yes, sir.
When you are removing the disc, how far posterior do you go? Do you go all the way till you see the dura?
I go all the way up to the posterior, and when you distract, you're releasing the posterior longitudinal ligament. That is very important. Yeah. And if there is any herniated disc fragment, you can put your probes and you have to, you can take the PLL out, but it is not required. If you're not able to distract, then you have to sacrifice the posterior longitudinal ligament.
So it's a kind of indirect decompression. You
Yes,
jack
sir.
up the height.
Yes, sir. It's always an indirect decompression.
Correct.
So you're not touching the nerve roots, and
Yeah.
that's why you're not getting any scar. And it's completely purely dependent on how much you are jacking it up.
So you're
yes, sir. If you are distracting it more than say 16 millimeter, the cage will always subside.
yeah.
The maximum you should reach is 16. The minimum, there is no extent to minimum, but make sure that when you do an intraoperative X-ray, the facet joints, they are opened up. The neural foramen has opened up. Then only you will get this. Otherwise, they will not decompress. Lateral, yes, it can. It can. It's mainly for lateral recess stenosis. Always an indirect
always
decompression.
indirect.
Anterior oblique X-leaf is always an indirect decompression. Yes, if required, you can take out. You are doing cervical spine surgery, it's almost same. Yes, you can. If you want to in lumbar spine, you can. We have tools which are available. I would not recommend in a normal person to go always laterally. If there is any disc fragment which is going there, then you can pull out that fragment from there. Yes, you can. All the way beyond up to the 50% of S1 or above, you can take them out.
Do you do artificial disc replacement surgery patients with modic changes?
Yes, if it is type 2 modic changes, they are most painful ones. So if it is a type 2 modic change with grade 1 or grade 2 facetal hypertrophy, mechanical devices, yes, I can. If it is grade 3, up to grade 3, you can very safely do an ADR with a viscoelastic one. The ESP is now not available in our country. They have stopped supplying to India from this year onwards. But it's available where you are practicing. If you want, you can get that.
Which disc are you?
Sir, I am using Bagheera right now. It's a temporary one. So we have designed our own ceramic viscoelastic. So because of the trade practices and the competition, so they have stopped supply.
How much it costs?
Sir, this ceramic one will cost around $8,000 because it's customized. It's for every person and every level it is being printed. And the ESP device is close to 4.5 lakhs.
How do you choose size of this artificial disc replacements in cases after microdiscectomy?
So after microdiscectomy, if you
Size loss.
So after microdiscectomy, when you take out the posterior longitudinal ligament and you remove the recurrent or the reherniated fragment, you have to go all the way up to the lateral and see the roots. If it is inflamed, if it is fiery red, then don't do an artificial disc replacement because you are preserving a movement there. And the nerve, it will take plenty of time to heal. We have tried steroids, giving steroids, placing an artificial disc replacement, even then the patient never healed. So you need to provide a quiet environment where there is no movement, and then you can perform an ALIF in that situation.
How you choose size of
So there are different.
cages?
So when you go in there, there are different sizers which are available. There are different templates. We just use a small, medium, and large footprint. we add, say if it is medium, then we have the distractors with us. We go to the maximum height, we see it on X-rays. With an ADR, you need to do plenty of X-rays. So you see the foramen, whether it's opening up or not, whether the facet joint has distracted or not. Stay there where it has distracted. You measure the height, you measure the angle, the lordosis, and then you assemble the device and you place it there.
I just wanted to ask whether we can do ALIF in a moderate to severe stenotic at L4, 5 or L5S1.
So moderate to severe stenosis का मतलब क्या है?
Sir, if it is suppose that canal diameter is less than around 4.5, 5.5 or 6 millimeter.
So canal diameter you are measuring antero-posteriorly in the midline?
Yes, sir.
No, I will not suggest you that. Up to, if it is an exiting and up to grade 1 or grade 2 canal stenosis, yeah, you can do that. 3 or 4, you can do an indirect decompression, but if the fusion doesn't happen, that patient will come back again with severe facet hypertrophy. Then you have to do another procedure. So that is a relative indication, but be prepared. If you're doing anterior, you have to be ready for the posterior, another supplemental posterior surgery. So I would advise you to go for the posterior only rather than anterior.
So one more question, that suppose if the pelvis is having high incidence, suppose that L5S1 disc is looking very, very down, still we can do ALIF, like how?
Yes, up to now we have tools. After I had to abandon this that live surgery, now we have even more than 45-degree inclination. You can get into L5S1. So you need to see the axis of rotation and you need to know the device. Every device has different axis of rotation, it has got different mobility. So you have to go all the way up to the back, all the way up to the back, all the way up to the posterior aspect. In AP it should be in midline, and in lateral it should be all the way up to the back.
Many times there is such space between the implant and the as we sometimes see during the ACDF procedures or
Yes. So what we have seen is that with ProDisc lumbar, the first generation, this gap it fills up because it has got HA coating in that, and it will fill up. It's very rare to see osteolysis, but whereas with viscoelastic devices, we are seeing osteolysis when this gap is there. So if you see this, you can take a small sliver of bone or you can put some graft on there to fill that defect. And you can get away with osteolysis. But if you're very right, the lumbar spine is always like this,
Yes,
dome
sir.
shape.
Yes, sir.
So there is always a dead space
Yes,
over
sir.
there.
Yes, sir.
So with viscoelastic devices, you have to be a bit careful. And we have sorted this problem with 3D printing, customized 3D printing and ceramic. It's biocompatible. The bone will grow in and it will catch hold of the ceramic end plates. And that is more stronger than metal and MRI compatible. So you cannot see any magnetic artifacts on MRI.
Okay, sir. Thanks.
So if there are no further questions, we can proceed with the. Is it?
Okay. ऑपरेटिव वीडियो दिखा ना अप्रोच वही है ठीक है so you want to see the approach. I will show it to you once more.
नहीं वो cadaver में दिखा.
Cadaver में दिखा देगा ठीक है.
Anything else? ठीक. So we'll proceed with the demonstration by sir. I request all the delegates to stay here. Okay, it will be telecasted here and you can ask the questions.
You know, it's very difficult to telecast an anterior approach. Why don't we take them downstairs? Yeah. Very difficult to telecast. No, I mean, they will come there after demonstration. Microscope is working. पहले लगा दे क्लैम्प.
राइट वाला इधर लाओ, लेफ्ट वाला उधर करो, जैसे यहाँ पे है वैसे सर एक कैमरा यहाँ से कुछ है नहीं रोटेट का.
अच्छा
क्या ऑफ के चलता है?
नहीं मेरा मतलब अच्छा यहाँ
वो अपसाइड डाउन आ रहा है इमेज ना. इधर से दे दो पीछे से.
ऑन कर.
इधर लाओ यार.
Sanchit, can you hear me? Sanchit? Pankaj sir, are you able to see the screen and able to hear us? Conference hall में कोई है?
हाँ सूर्या नहीं अभी we cannot see.
You're not able to see?
No.
Okay. Okay. Are you able to see now, sir?
No. Yes, now we can see.
Okay. थोड़ा वॉल्यूम बढ़ा दो. Yes.
Yeah, cadaver, yeah, live.
Start.
Yeah.
Okay. So tomorrow you will meet Dr. Omesh Srikanta, and he will talk to you about the patient positioning in OLIF, which is very important. In ALIF, the patient lies supine. Some people they stand between the legs, but what I do, I keep them straight and with arms abducted on both the sides, supine position. Place a pillow below the knee so that the hip and knee are relaxed. You paint right from the zippy sternum all the way up to the mid thigh. You drape only this area. You keep everything sterile here for just in case if you have to do some vascular intervention like Fogarty's or anything has to be introduced, you already have a sterile area. So beaten in paint, drape, and then you drape this thing. So today we are using a retractor called Mars Anterior. So it's just like any other anterior retractor system. You might have used Integra, Bookwalter, Thomson, lot of things. So just like the general surgery or a liver transplant or a kidney transplant surgeon. So there are two table posts attached. There are two table posts and there is a connecting rod in them and various articulating joints. There is a ring which we will assemble and apply after the approach is done. And it can be applied in whatever size of the patient. So there are various sizes of the rings, and you can increase or decrease the size by adding extenders there, which will be connected with this. But placing this ring and then doing an approach is difficult. So it's always better to do an approach and then place the ring, until unless you have Thompson's or Integra retractor. So you can assemble your retractor and you can perform your approach. So like Dr. Surya talked to you about the approach, we always go anterior, midline, infra-umbilical approach for L4-5 and L5-S1. And if it is L3-4 or L2-3, then you have to make a curvilinear incision. Somebody took a graft kind of a thing from this cadaver. So you can do a curvilinear incision and go extend your incision all the way up there. So this is right side on which I am standing, left side, cranial, and this is the place where pubic symphysis is. These are cadavers, they are very stiff, but in normal patient, when the patient is under anesthesia, you can palpate the L5-S1 straight here, and then you can plan your incision. So I place my incision. You can give Pfannenstein incision for L5-S1. For Pfannenstein incision, it has to be transverse. You can check on X-rays whether you are on right place or not, directly in front of L5-S1. If it is slightly below or above, then it will create a problem. You want to mark? Okay, you can mark on X-rays. ये रख ले, कुछ और दे दे, straight artery. Height नीचे. So this is also very important. You need to see whether the patient is very well lying on a table where the C-arm can easily move in or not. Yeah, this is L5. थोड़ा सा tilt करना मेरी तरफ. और थोड़ा, बस ठीक है, कोई बात नहीं, इतना काफी है.
Pankaj sir, are you able to see?
Yes, we can see.
Okay.
So I just placed some metallic marker over there just to see where exactly L5-S1 is. This exercise is not required. You can, it's only for teaching.
Shoot karo.
Yeah.
X-ray. नहीं है. Shoot. नहीं. मनोज. नहीं है, यहाँ पे नहीं है. I think we will take बीच में ले लेंगे.
Okay. So can you move this picture? So the C-arm is not working, so we will take an X-ray later. But most of the times you don't need any X-rays till the time you start doing disc preparation. So place an incision here Can you see?
Yes, yes.
Pankaj sir?
Yes, yes.
So anterior midline, placing a big incision. This is so later on when you come to the cadaver, you can practice this. This is all fat. Langenbeck लेना. एक और. Okay, give me a gauze piece. So once you remove the fat and everything, you will see the central white thing there.
You're not supposed to come.
Can you see this?
Yes. Yes.
This is the linea alba.
So generally we telecast it there.
You might have done your general surgery training, na? Neurosurgeons. So उनके लिए तो बहुत आसान है. Yeah. This is good. Yeah. Can you see this white color thing in the center, the dense white thing?
Yes, yes.
So probably because of light and reflection, you may not be able to appreciate, but this is the dense white thing over there.
Okay.
You can retract, your assistant can retract, they can remove all the fat and everything, and then you take forceps. Lift it up in the center and cut this. Okay, so once you cut this, what I normally do is place my finger, make an enough space so that I can place my finger there.
Sanchit, are you able to hear?
Yes, yes, we can hear.
Place my finger there, go all the way below the linea alba. You don't have to use so much of force because this is bit stiff. Use your finger to dissect everything from beneath, and then go above, dissect everything from beneath, from the midline. Make sure there is nothing in the linea alba and all the muscles and everything are away. Lift it up and then cut this. In fatty people, it's very difficult to predict. You will see some peritoneum, previous cesarean scars. They stitch everything from here only, so there are chances of damaging the peritoneum there. So I am cutting only the rectus sheath, anterior rectus sheath. Just below the belly button, in the upper 1/3 quadrant, you may see the arcuate line. Now you can see the rectus muscle on my side, on the right side, and there is rectus muscle on the left side. You see this fat there, you have to enter this fat plane. All you have to do is splitting, like what I have did. Yeah. Okay. So I'm going below the rectus muscle here. The left side rectus is below the retractor, like this. Your assistant will pull it up. Sir, iski zarurat nahi hai ab. And now I'm entering in, and I'm going towards the left iliac fossa. It's very easy to detach peritoneum from that place. I'm not sure whether you can make it or not from inside. इसके अंदर डाल सकते हो क्या? So it's more or less a very blind approach. Yeah. So this is just below the rectus. No, light नहीं जा रही. Light अंदर डालना है. यहाँ से. Hey Meta, start recording.
So you are between the two recti.
Yes. So this is on my right side. The left side is here. Just we have placed a retractor just below the recti. You will see the thin membrane. This is the peritoneum. What I wanted to show is that there is superior epigastric vessel down there. Can you see that? Sir, इधर से yeah, inferior epigastric, sorry. So you need to protect that, and you will open the fascia just below those vessels. So for me, it's 50-50 chances. I always damage them because I do them blindly. So you have to be a bit careful. If it bleeds, then like it. Can you see something inside now? Okay. So can you give me peanut? It's possible to go all the way to the lateral to the rectus on the left side and then. Yes, sir. It is. Yes, sir. It is possible. Go laterally to the rectus, but you are cutting off the blood supply and you are damaging rectus muscle. And you may damage the nerve supply, so the rectus become weak. So probably this is one of the technique where you can prevent damages to the rectus muscle. Yeah, can you see from the classroom? Can you see the
we can
shining
see,
thing?
yeah.
This is all peritoneum.
Okay, yeah, we can
This
see.
is all peritoneum there, and just below that there is inferior epigastric vessel where pointing.
Yeah, we can see.
Deep there,
Yeah.
and the peritoneum will always don't go above. If you go above, it's very difficult because all three layers are forming there. So see, easily with my finger, I am just moving them across, teasing them away. Okay. So once you are the attractor, now the assistant will lift it up. You can take this off. अब जो भी सर्जरी होगी है ना आपके असिस्टेंट के फोर्स के वजह से हो रही है. इफ यू आर अप्लाइंग टू मच ऑफ फोर्स देन समथिंग इज रॉन्ग. सो द असिस्टेंट इज लिफ्टिंग इट अप एंड यू हैव टू काउंटर दैट फोर्स एंड move the peritoneum across. Can you see all this fat plane and everything? Just have to strip it off. It strips off very easily in this cadaver and it strips off even easily in a normal person. Okay, so I have reached up to the iliac fossa. I'm moving the colon and everything to one side. I have a peritoneal tear. Sorry. Okay. So now I am into the abdominal cavity. Okay. So for the classroom, can you see a muscle down there? Let
Yeah.
me point it out. That is the psoas muscle. Can you see this muscle?
Yes.
This is the psoas muscle.
Yes.
Okay.
Okay.
This is the psoas muscle. I have ruptured the peritoneum because the cadaver was a bit too stiff over there. So anyway, and then you move your peritoneum, sigmoid colon and विक्स सभी स्टूडेंट्स को ना विक्स लगा के मास्क लगाने के लिए बोलना, नहीं तो बहुत स्मेली होगा. Yeah. Yeah, somebody has done something in this cadaver. है ना, कोई वैस्कुलर प्रोसीजर हुआ है क्या? Yes. हाँ, क्या हुआ है? क्या किया है इसमें? कुछ तो किया है. See? No, I don't know, but something was done here. स्पंज दे दो बहुत सारे. ये सारा अंदर से है ना, ब्लड और वो सारा कुछ आ रहा है. सॉरी. ये आता रहेगा यार. हाँ ना, कोई बात नहीं, ठीक है. Something has been done for his yeah, something has been done. You see, ये देख. Can you see this? बॉवल है पूरा और उसके नीचे जो ब्लड वेसल्स है वहीं से पूरा ब्लीडिंग हो रहा है. कलेक्शन है पूरा. कोई बात नहीं. Abdominal injury.
Maybe retroperitoneal hematoma due to
Anyway,
trauma.
we'll suck it up and see. ऑन कर ले. कर रहा है.
एक स्पॉन्ज देना. ओके. अच्छा रिंग ले यार, रिंग लगा के उसी से कर लेते हैं. रिंग लगा. So we have seen the psoas. There is little bit of bleeding there inside. So we are assembling the ring, and then सर यहाँ पे लगाओ, इस पे. Wait. संजीव कहाँ गया? ठीक है. राइट. संजीव 140 का ब्लेड दे. 26. I'll place retractor and then we'll show you. वो पेरिटोनियम रप्चर हुआ और अंदर जो भी कलेक्टेड फ्लूइड है वो सारा बाहर आ रहा है ना. नहीं कुछ नहीं था. पता नहीं है. पेरिटोनियल कैविटी के अंदर रहा होगा कुछ, वो आ गया. पेरिटोनियम रप्चर हुआ था ना. 140 ये देना स्क्रू ड्राइवर. So these are very versatile. They can move in any direction. You have got various lengths, 16, 26 and 50 millimeter, various depth, and everything can be controlled. So these are very versatile and very expensive ones. Radiolucent carbon frame. So even if you retract vessels with this, it is not going to damage any vessel or anything. 50 mm width का देना. 140 same. वन 120 का एक देना. Normally around 3 to 4 centimeter for 2 levels. वो हटा ले. संजीव इसको टाइट करना. हेडलाइट नहीं है. बुक पे मिल जाएंगे पीनट्स. लंबी आर्टरी, सबसे लंबी. संजीव 140 का दे. 26 में.
कैमरा का हाइट थोड़ा ऊपर कर दो ना तो मुझे सर ये डंडे पे अगर कैमरा नीचे ही रखना पड़ेगा.
ये अटक रहा है. दूसरा अभी टाइट नहीं. अभी नहीं. अभी आप टाइट कर. Yeah, that is the peritoneal tear जहाँ से leak हो रहा था. But anyway, just so can you ये आ रहा है ना बीच में? ये नहीं आ रहा, ये आ रहा है. लॉक कर दे. Give me small gymnastic. Okay, रुक जा. No, no, no. I want to show this thing. Can you see this white color thing with the blood vessel? This is a ureter.
Yes, sir.
अब हो गया.
थोड़ा ना इधर एंगल. हाँ, यस.
बस इतना काफी है. Right. यहीं पे फोकस रखना, इससे हो जाएगा. Okay. So you can see this retractor carbon fiber blade. Can you see this white color thing there?
Yes.
Can you see this white color thing?
Yes, sir, we can
जा
see
रहा है.
that.
There is a small leak of blood vessel. In a living person, you will see the peristaltic waves here. This is the ureter. You need to identify this. It's not that difficult. It comes with the wall of the peritoneum. And then you have to stay just below that. And you will see this thin layer. This thin layer is all peritoneum. So you have to, kind of dissect and move it around, which I'm trying to do that. Okay. Yes, always, always. So it is the most important structure. It has to be identified. It has to be preserved. Ureter. Okay. So yeah, बहुत length होता है. Okay, so the ureter is gone. Can you see this tube-like structure there, white color thing?
Yes.
That is the common iliac artery for the left leg. And somewhere here will be the common iliac vein. Cadaver is bit stiff, so you will not feel, the strength. Okay, so this is the common iliac artery. This is the external iliac artery, and you will see a white color thing there. That is the internal.